Hello, I'm Pam Nicoll and I'm the Programme Director for the Remote and Rural Healthcare Education Alliance, or RRHEAL for short, which is part of NHS Education for Scotland. This DVD has been devised in order to give you an insight into some of the opportunities that are available to those who choose to become healthcare professionals working within the remote and rural areas of Scotland. RRHEAL is here with the support of the Scottish Government to ensure that education programmes are produced that are accessible and suitable for remote and rural practitioners working across Scotland, both now and in the future.
We have to deliver to a vast geographic area, an area probably the size of Belgium in landmass and extending on to Western Isles, Orkney, Shetland and all the other remote and rural parts of Scotland, including Dumfries and Galway and the borders. Difficulty with geography is communication, and in order to deal with this problem, what we do is we develop innovative ways of delivering education by using the very latest technology possible, whether it be video conferencing, camera systems which can record education, and by devising systems whereby our tutors go to people's practices and deliver education such as dental nurse education in their practices anywhere in the remote and rural parts or islands of Scotland. I do believe that NHS Education has developed the finest teaching facility in the whole of Scotland here.
I think these days throughout Scotland in remote rural areas, career development pathways are very, very good. There's good postgraduate training that goes on throughout Scotland in these areas. Very good networks of clinicians, many of them building special interests with their own area of expertise, and I think the potential to develop career in specialist areas or in dental education is very, very strong in Scotland.
This is the clinical techniques room, and in this room we have facilities for students to practice a wide variety of skills that are essential to the practice of dentistry. This morning we have students practicing using scaling instruments to remove tartar and stain from artificial teeth mounted in artificial jaws at each of the stations. We also have a live link-up with the remainder of our school, which is based in Dumfries, and you can see that on the television monitor behind me. This live link-up enables us to simultaneously teach students in Inverness and also in Dumfries.
People think that there's a misconception that people that work in remote and rural areas, they're in some kind of a backwater, but I have to say that's not really been my perception at all. I think in a lot of cases that they have some really good technology. Some of the equipment in some of the dental surgeries is as good as anywhere. And indeed, as far as their education and training, in my experience, they actually value the education and the training that they get more so than their counterparts in some of the more urban areas.
One of the examples we have in occupational therapy at the moment is at the professional forum that we hold twice a year, which is open to all staff to attend. We video conference, so we have two sites, one in Argyll and Bute and one in Inverness, and we link the whole forum so that people can attend from all over the Highlands with relative ease. It doesn't really matter where you are as a patient or where you're seen as a patient, you'll have access to all the range of specialist advice that you ever require at the touch of a button.
Certainly in Dumfries and Galway, something I hadn't ever looked at before was the likes of the telemedicine and the teleconferencing, being much more effective with using your email system and your ITs, just keeping in touch that way instead of relying on, you're going to see each other definitely every day, you don't hear,
As GPs we look after the ward for a week at a time, and that week runs from a Thursday to Thursday. And on a Thursday morning we have what we call our handover ward round, and that's not a ward round that goes around the wards and sees patients, but we sit down and we discuss the patients that have come in and out of the unit over the previous week. And that's useful because it gives us some continuity and overview of what's going on. It also gives us the opportunity to discuss cases that we've struggled with as individuals maybe, or to discuss things that we're not quite sure what's going on there. And we use that time, we review those cases in order to identify things that we've learned, so learning points that have come out of that work, but also to identify learning needs that we may have. But we use that time to get the junior doctors and medical students that may be attached to us to present the cases, and we get them as the junior doctors to to present it. So in actual fact, the medical ward round is one of our biggest training and teaching sessions that we have in the week, and I think we all find it very useful, and it works well, and it brings us together as a team and keeps us cohesive. Now the technology has really progressed certainly over the 9 years that I've been here, and it allows us to do these things. We are able to transmit our x-rays so that the remote viewers can see the x-rays. We've also got a document scanner, so we can put ECGs onto that and scan in any other paper-based information. We also obviously use email, so we'll email out the lists of the patients so that the remote practitioners can have the same information in front of us. So it's a way of using technology to keep us in touch. Video conferencing in Orkney started through an educational project which was called the North of Scotland Tele Educational Programme, NoStep. And that started with NoStep putting in 5 video conferencing units into one in the Balfour Hospital and 4 into some of the outer aisles. And NHS Orkney very quickly recognised the benefit of this, and in fact all the GP practices except the Kirkwall ones have got video conferencing units. And therefore, as a result of that, all our educational stuff is video conference, so that any of the outer aisles, GPs or nurses can come in and join in on that. Most of our management meetings are video conferenced, whether that's just for internal NHS Orkney stuff or a lot of the stuff that we do with Edinburgh and with Aberdeen. And in the acute stuff, we also have a link now with York Hill.
I've been quite pleasantly surprised about the sort of level of support that there seems to be up here, and it seems that there are lots of good facilities available. The training opportunities are quite good, and especially early on, as you get quite a wide range of treatments, because you perhaps don't have the same people, maybe a specialist in neurosurgery sitting next door, so you don't quite refer away your relatively simple procedures. You get down and do them yourself.
I was like everybody else. I came here for the lifestyle choice first and foremost, not for the career. But actually the career has been very surprising because of the creativity that we have to use. We don't get stuck in the same old, you do things this way because you've always done things that way. We constantly have to look for more imaginative, creative solutions. I think often when they first come, they're more nervous than anything about what is the support going to be like. These are newly graduated staff who are obviously coming out wanting support and to develop. And the traditional route has always been through the big acute hospital, so they're going slightly different to that traditional experience. What they get, I think, from coming into this type of area is the variety that they have come through. So they carry a very mixed caseload, whereas in the big hospital you carry quite a specific caseload around one specific area, and then you chunk it off. You usually do 6 months in that area and 6 months in another. What they have is a completely varied caseload right from the start.
Orkney's a larger community, it's 20,000 people, and of course I don't know about all those 20,000 people, and they're certainly not all in our practice list. Our practice list is 4,000, but when you've been here for a number of years, you have a very good understanding about the links and the networks that there are within the community. And I think one of the lovely things is that when patients come into the ward, for example, normally at least one of the people working here will know them as an individual in their own environment back at home, and you therefore have that closeness. And even if you don't know the person or the relatives, often they'll know of you, and there's just that closeness. I think one of the huge advantages that we have, I've got 3 youngish boys now, ranging from 9 to 13, and the opportunities that they have here are just unbelievable. When you go south, when we go south down onto the mainland or down into England, and we recognise and realise all the things that they have. The difficulty that people would think is, have you got, is there enough for the kids to do? The problems that we have here is that it's far too much for them to do, and you're needing to make decisions as to what, or they're needing to make decisions about what they're going to do, what sport they're going to do, what sport they're not going to do, because there is just so much going on. And you've got all the freedoms of getting out in the sea, whether you're sailing or fishing or whatever. So all those other things.
The way I do things it has to be different sometimes. You have to change your practice to make allowances for the fact that you're far away from a CT scanner, that you're far away from a laboratory sometimes, that your patient might have to take a a couple of ferry journeys, for example, to get to a large population centre if you need to. So a lot of my skills are needed to adapt to the setting, and it's one thing to think you're flexible or to know you're flexible. It's another thing to put that into practice.
I would say that the skills that you require here, you have to be more diverse, you have to think more imaginatively about how you could deliver services, and you certainly have to break down barriers with your traditional boundaries of your role and what you previously would have considered to be your traditional role and others, and be prepared to take on and also give over parts of the roles. So I would say it's certainly more challenging but also rewarding.
And I suppose we're the same. I've learned things about occupational therapy and measuring for pieces of equipment, which would be the appropriate bit of equipment that I would never have got in a traditional nursing role. So again, I can go into a house and look at somebody and then even take back to Wendy, I've measured this for this piece of equipment and I know how to do that, so I'm giving the appropriate information back to that professional to then give the appropriate equipment, which nursing roles traditionally would not have got that before.
Now you could say, well, how do I actually practice as a consultant surgeon in a day now when we have increased super specialisation, and therefore there's going to be small numbers of cases because our base population in these smaller hospitals is around between 20 and 40,000 patients, which is very different from the bigger district general hospitals serving about 250 to 400,000 patients, and then the big teaching hospitals which serve the bigger conurbations of up to 1 million or more people. So it does make difficulties, and we have to overcome them to try and save patients having to travel huge distances to have treatment. Well, we have a multidisciplinary team meeting that happens weekly, and the consultants involved in Inverness, which is our tertiary centre, that'll be the colorectal consultants, the radiologists, the pathologists, the oncologists, the stoma nurses, the palliative care doctors, all meet on video conference. And the consultant surgeons and some of the physicians from the rural general hospitals in Wick, Stornoway, the Western Isles Hospital, and in Fort William, and in the Lorna Irons Hospital in Oban, actually meet together, video conferencing for 2 hours each week to discuss every new case of gastrointestinal cancer. And during that time, my cases with colorectal cancer will be discussed, and my colleagues as well will bring those cases there, and we get a joint decision on the management of them.
The great benefit of the new way of teaching students so that we can develop courses for people working in remote and rural areas is that, first of all, there was always a huge cost for people to have to move to the central belt or south to teaching establishments. By using blended learning within the rural areas, students can access education within their own area. The purpose really, from the point of view of manpower, is that this provides people with learning resources in their own local area, and we're much more likely to retain the workforce within the areas of Scotland which we've had great difficulties in attracting professionals in medicine and dentistry to work. We can expand the provision of care by facilitating people who wish to continue to learn without them having to come to major centres. We can also use our core workforce much more productively. If I have a tutor working here in Inverness who's able to broadcast via video conferencing, for example, to other areas of the country, that is a much more effective use of that tutor's time, and he or she can touch on the education requirements of a much wider group of learners.
So we now have, about to start in July of this year, a rural surgical fellow. And this is a 1 year to 18-month appointment where the trainee will come and have tasters in an island or a mainland setting for 2 or 3 months to see the sort of work that they would be doing, and then would go back to one of the bigger units to train not only in the general surgery and meeting the people that they may be appointed to, if they're appointed in that area, to work alongside them, but also to do a little bit of ear, nose and throat, eyes, some gynae and obstetrics, because if they're working in an island setting, they may be required to do caesarean sections, and to learn the technique from the appropriate trainers in the bigger units, who they will also work alongside, and they can then have confidence in them to carry out the procedures properly. How would I sell the practice in a remote and rural environment to a recent graduate? I think the first thing that I would say is that if you want a general and varied career with lots of challenges for managing patients who will present on the doorstep with obviously the whole gamut of medical and surgical problems, then coming to work in this environment is for you.